Right, Dr. Albin, are you ready?
Yep, absolutely.
All right, so if you could go ahead and share the slides, we'll go ahead and get started. And again, good morning, everyone. My name is Danielle Davis, and I'm going to be coordinating things on the back end of the event. If you have any questions, then please put your questions in the Q&A box, and we will get to your questions at the end of the presentation. Excuse me. Just so you all know, this event is being recorded. So you'll have the opportunity to go back and to watch the presentation. And then if you want to share it with someone, then feel free to visit our YouTube page, and the information will be posted, and you'll have that in your email as well. Dr. Albin, could you make it big for me?
Yeah, I'm trying to. I think I have to move the.
Okay. All right, and also please fill out the evaluations. We appreciate your feedback. So you will receive a survey link at the end of the presentation. I'll place it in the chat box, and then you'll also get an email. So if you can just complete that, that would be greatly appreciated. Next couple slides, please.
There we go.
All right, and yep, right here. Okay, so for those of you that are new to the Michigan Alzheimer's Disease Research Center, we're a research center in Ann Arbor, and a collaboration between the University of Michigan, Wayne State, and Michigan State University. We offer a variety of dementia-related research studies, but in honor of Lewy Body Dementia Awareness Month, I want to bring to your attention the Rennie Lewy Body Dementia Initiative, which is housed within our center and offers support for individuals living with LDB as well as their caregivers. And so we also have monthly support groups as well. Next slide, please. And here's some information about the monthly support groups that we offer. If you're interested in learning more, then feel free to contact Renee. Her information is posted on the screen, but if you don't have a pen or anything to write it down, then you can email me and reach out and let me know. If you're interested in learning more about this or other research studies, then contact me and I can help put you in contact with the right individual. So it gives me great pleasure to introduce our speaker for today now. Dr. Roger Albin is a professor of neurology, associate chair for research, and co-director of the Movement Disorders Clinic in the Department of Neurology. In the University of Michigan Medical School. In addition, he serves as Chief of Neuroscience Research at the VA Ann Arbor Healthcare Center, Geriatric Research Education and Clinical Center. The present focus of Dr. Albin's group is uncovering the basis for non-motor sleep disorders, depression, dementia, and problems in Parkinson's disease. The hope is that understanding how specific brain alterations cause specific clinical features will lead to improved treatments. So now, without further ado, Dr. Albin, take it away.
All right, thank you. Thanks for that introduction, Danielle. So I'm going to talk today about some work that we're doing in our Udall Center that we've done and we're continuing to pursue. Now, I think Parkinson's disease and Lewy body dementias are sort of seen as cousins, but conventionally described as one being a motor problem with movement and the other being a problem with thinking. What I'm going to talk about today is really how this is really a pretty artificial distinction, and how these two sort of things that we often put in separate categories sort of interpenetrate with each other, and how really trying to study the brain or brain mechanisms it really requires thinking about both these aspects in order to make some progress. So just first of all, these are my disclosures, none of which are relevant to today's talk. We're very grateful to receive grant support for our projects from the National Institutes of Health, Parkinson's Foundation, and the Farmer Family Foundation. Now I'm going to talk about why we're interested in this particular aspect of Parkinson's disease. Then I'm going to talk about how we study this in humans, particularly the imaging research tool that we use, and then talk a little bit about some animal experiments done by investigators in the Udall Center to try and explore some of these questions based on, or originally inspired by some of our human work, and then talk about a human experiment which is aimed at taking the first steps towards developing some form of treatment. So the problem that we're focused on is really gait and balance problems in Parkinson's disease. Now, there's a reasonably stereotyped evolution of these problems. So typically in early Parkinson's disease, individuals are slow, they're slow with walking, they have slowness of using things like limb movements, hand movements. And with conventional treatment, which is replacing the chemical signaling dopamine, we can produce significant improvement in that slowness, which includes things like walking. But with disease progression, Parkinson's patients begin to experience more difficulties with gait and balance problems. And these, unfortunately, are not particularly responsive to our conventional treatments. And in more advanced Parkinson's disease, people have a very high rate of falls, and then they develop some other interesting and unfortunately very troublesome gait problems, which are generally called freezing of gait. And again, these are not particularly responsive to our conventional treatments and are a significant cause of distress for patients, and also lead to falls, things like hip fractures, wrist fractures, and become, major difficulties for patients with Parkinson's disease. Now, I'm just going to show you a video briefly here. This is from the Lancet, and just to show a couple of these phenomenon. And this gentleman, this is in the Netherlands, actually. As you can see, he gets to this square of carpet and gets stuck. So this is a fairly typical freezing phenomenon. Something about some signal or cue in the environment results in freezing, and then the legs seem to get stuck and there's difficulty with initiation of movement. And this also commonly occurs with problems with turning, for example, as you can see here. So something about stopping, starting, turning, environmental cues can produce this type of freezing behavior. And this often leads to falls, and often very damaging falls as well. And I think the next little video clip is this is a typical experience of an individual going through a doorway. You can see as this gentleman approaches the doorway, he'll actually have some additional freezing. So again, some kind of environmental cue changes the way your brain functions in terms of your motor behavior. Okay. Now, these are both troublesome and common problems. So these two graphs are from a very well done community-based study in Great Britain. And on your left, what you can see at the bottom, HY1, HY2, and HY3 represent advancing Parkinson's disease. And at HY3, this is when patients begin to experience some difficulty with maintaining an upright posture. So we evaluate this in the clinic. Some of you have probably experienced this with a very simple thing. We stand behind patients, hold them backwards by their shoulders, and we see how many steps it takes for them to maintain their balance. And what you can see here on this axis is a measure of quality of life. And the higher the number, the worse the patient reports their quality of life. So what you can see is when patients are in a situation where they've had problems maintaining their posture, there's a marked decrease in their quality of life. And in the right graph, you can see how common this is. So as about 5 years after diagnosis, about half of the patients in this study actually were experiencing these difficulties with maintaining upright posture. And this continued to worsen over time. So again, these are problems that are very bothersome to patients, very bothersome to their families, and very, very common in the course of Parkinson's disease. Now, a key point is that it really, when we're talking about things like walking, this is actually a pretty cognitively demanding task. Now, we tend to think of walking as being very automatic. We don't actually consciously think about it when we're doing it. But in fact, it requires a lot of cognition. In particular, it requires the ability to pay appropriate attention to your surroundings. So we've all had that experience of walking down the street, becoming distracted, and then tripping or perhaps actually falling on some minor change in the surface of the sidewalk or the ground. But these problems are really exacerbated exacerbated in Parkinson's disease and even in normal aging. So on the right part of the screen, these are studies done in Australia of not Parkinson's patients, but just normal elderly patients. And what you can see in the top graph, EF stands for executive function. This is a measure of simple cognition which measure things like your ability to pay attention. And the patients, the individuals in the study were divided into two groups, those with good executive function and those with worse executive function, and then followed for 2 years. And those individuals had the worst executive function, which includes the ability to pay attention appropriately, had a much, much higher risk of falls than those who had good executive function. Now, in the lower graph, you can see a similar analysis. In this case, DT stands for dual task. And this is a very simple way of measuring how your ability to pay attention impacts your gait. And the way this is done is that an individual in the study is just asked to walk down a hallway, and there's measurements, some simple measurement of gait, like how fast you can walk and whether or not you're regular in terms of how you place your feet. And then there's a distractor added. And this is usually something like counting backwards from 100 by sevens. And in that very simple distractor, if there's a change in your gait, even a modest degree of change, then your risk of having a fall is much, much greater of the subsequent 2 years. So even just simple attentional distractions can cause falls in some normal elderly individuals. And these problems are much, much greater in individuals with Parkinson's disease. Now, in order to investigate what's going on in individuals who have these kind of problems, we need some kind of tool that we can actually measure and examine the relevant systems in the brain. And what we use for a lot of research is an imaging method called positron emission tomography. And this is a lot of sophisticated technology. This is a nuclear medicine method. It involves the generation of exotic radioactive compounds, which our chemists can then label, can actually then stick to drugs or other compounds, which allow us to target very specific brain systems. This requires a lot of technology. We have a cyclotron in the basement of the University Hospital to develop the isotopes. We have to be able to label the compounds that we're using with a lot of sophisticated chemistry in a safe way. We have to put it into patients so that we can measure it in the scanner, and then we have to use a lot of math to reconstruct the images. But the end result is our ability to actually measure things in living patients that previously you could only measure after death. And just to give an example, it's well known in Parkinson's disease, I think most of you are probably familiar with this, that there's a deficiency of the chemical signaling, the chemical signal dopamine. And dopamine is made by these neurons in the substantia nigra at the base of the brain, and they send projections into the forebrain to produce dopamine. And in Parkinson's disease, this system degenerates, so you have less dopamine in the brain. And using PET imaging, we can measure this directly in living patients. So this is a normal 30-year-old, a normal 70-year-old, and then this is one of our Parkinson's disease subjects. And what you can see is that we can measure these dopamine-containing neurons quite precisely. And you can see the dramatic difference between the Parkinson's disease patient and a normal elderly individual. And we can do a lot more than make pretty pictures. We can actually measure this with some precision. So this is actually a study, the round circles is a study of normal individuals from around age 20 up to around age 80. And we've known for many years that there's a normal age-related loss of these dopamine nerve cells in aging. So you lose about 4 or 5% with every decade after the age of 20. And what you can see here is this is exactly what we see in this study. So we see about a 4 or 5% loss over the course of 60 years. The bottom here, these squares, these are the Parkinson's patients. And clearly they're a very different population than normal individuals. So again, we can use this type of technology to measure things in living patients that and actually quantify them in a pretty precise way. So in order to determine what's the relationship between those changes and some of the changes we see with different clinical characteristics of our patient populations. Now, what we've been particularly interested in is another brain system called the acetylcholine system. And this is a little bit like the dopamine system. This chemical messenger is made in the groups of nerve cells down at the base of the brain, but they project widely throughout other brain regions. And we know something about the normal functions of this system, particularly what's called over here on your left, the basal forebrain system. This is a system that's involved in learning, it's involved in memory function, but it's also particularly involved in attentional function. And just like we can do with the dopamine system, we can measure the acetylcholine system in living individuals using PET imaging. And this is a set of normal combined images from normal individuals. And you can see this is the normal pattern of the way this system is constructed in the brain. And using this type of normal data, then we can then see what differences there are in patients with Parkinson's disease or other disease processes. And so this is just an example we used with PET imaging. So this is a normal individual on the top, an individual with Parkinson's disease. And here on the left, you can see the PET method that we use to study the dopamine system. And you can see it's markedly abnormal in the Parkinson's subject compared to the normal subject. And here is a study of the acetylcholine system. Again, this is the normal pattern. And here is an individual with Parkinson's disease, clearly quite different. Now, we know that we can then demonstrate there are widespread reductions in many patients with Parkinson's disease, but not all. So you can see here on the right, this is the study of a group of Parkinson's of normal controls and then Parkinson's patients. And you can see there's quite a bit of overlap. So many of our Parkinson's patients, the acetylcholine system is normal, but in quite a few others, it's well below normal. And what differentiates these particular subjects? Well, what differentiates them in part is the fact that they actually have different motor problems. And in particular, these individuals who have the markedly diminished acetylcholine system, they're the ones who seem to have the greatest propensity to have problems with falls and freezing of gait. So this type of analysis led us to look at in more detail at the way this particular brain system interacts with the deficiencies of the dopamine system to produce problems with falls and balance. In order to do that, there are things that you can't do in humans. You can't directly manipulate these systems, but you can do that in animals. So one of our colleagues, Dr. Martin Sartor, who is well known for his studies of the acetylcholine system, developed an animal model in which he partially destroyed the acetylcholine system going from the base of the brain up to the cortex, the thinking part of the brain, and then partially destroyed the dopamine system as well. Not completely, but just partially. And then he can use that combination of lesions in rats to study how that would affect gait and balance. And to do this, you actually have to do this in a fairly demanding way. You just can't watch a rat walk like you can watch a human walk in clinic. Dr. Sartor developed a number of tests actually to examine walking and balance in rats. And in particular, he developed a test which rats are walking across this beam, but the task is made much more demanding, that the beam can be tilted, the beam can be rotated, and then you can introduce distractors. So just the way you would distract a patient during a study of gait, you can actually, in this case, here's a doorway distractor. And down here on the bottom, this is a rat who's being distracted by being presented with a food item as they're trying to cross the balance beam. In particular, this is actually Fruit Loops. Rats really appear to like Fruit Loops very much. So let me just give you an example of the type of analysis. This is what happens. Now, the first slide is just a normal rat crossing a balance beam. And with a distractor, there's a doorway here. Let me go back there. There's a doorway. I'll point to it. And here's the doorway down here. And you can see the rat's walking across the beam. And he just goes right through the doorway, no difficulties whatsoever. Now, this is a rat who's had mimicking the type of thing we see in Parkinson's disease, some acetylcholine problems and some dopamine problems. And you can see he gets the doorway and he gets stuck. And then he actually, as you can see, he's retrieved so that nothing bad happens to him. Let me go to the next one. This is the rat. Now, this is the second distractor here. This is, in this case, using a food item, a Fruit Loop. And again, first you'll see the normal rat walking across the balance beam. and he gets the Fruit Loop and keeps going. And in contrast, this is the rat which is like has the partial acetylcholine and the partial dopamine lesion. And when he gets, you can see, first of all, he's a little hesitant to start. He's a little slower going across the beam. He gets the Fruit Loop. He can't get it. He loses the Fruit Loop. And there's a net underneath the apparatus, so nothing bad happened to the animal. This is very much like our patients. Our patients are walking. There's some distractor, a doorway, something else happens. They get stuck. They freeze. And unfortunately, many times they fall. Now, what this helps us particularly do is identify a potential treatment target. So based in part on work done by our colleague, Dr. Sartor, and other scientists in this area, we actually know a lot about how this acetylcholine attention system works. And in particular, we know that this is a system in which nicotine acts. So nicotine, it's well known, it's been known for decades that in fact, one of the things that nicotine does is it actually enhances your attention. So that individuals who smoke will often tell you that they feel sharper, cognitively more alert after they have their first cigarette of the morning. And in fact, this is true. Nicotine actually does, to some extent, increase cognition a little bit, particularly by improving people's attentional capacity. But what this implies is that if this acetylcholine system is deficient, and if we have a nicotine or a nicotine-like drug, we can actually use that drug in theory to partially overcome some of the deficiencies that result from loss of this acetylcholine system. And so in particular, we focused on this nicotine receptor and to see whether or not we could produce any evidence that this idea would be worth pursuing for treatment. And one of the things that Dr. Sartor did is he used some compounds which are nicotine-like, ABT in this case, and actually tested them to see whether or not they would improve the fall risk of animals in this animal model of Parkinson's with falls. And in fact, it decreased the fall risk by about 50%. So this suggests, in fact, that this would be worth pursuing. So we decided to pursue a human experiment. Now, just to make a fairly basic point, this was not a clinical trial. Our goal here was not to see whether or not giving a nicotine-like drug would actually improve gait or balance or change fall risk. Our goal here was to see whether or not this was a plausible idea. This is what's called target engagement. And the idea of target engagement is you have a drug or some other intervention, and you can show in humans that it's acting the way you think it acts. And then if you can show that, then you have a good reason to go on and actually do a real clinical trial. Now, one of the problems with drug development is that this probably isn't done frequently enough. So, people will try potential therapies that are really not doing what you think they're doing in a human being, and consequently, when they get to clinical trials, they fail. So the idea here was that we could give a nicotine-like drug, we could produce some predictable effects that we would be consistent with the way we think this is working. And if that worked, then we could maybe at a later point go on to an actual clinical trial. Now, again, we were able to use PET imaging as part of this experiment. So one of the problems with doing drug development or identifying drugs for treatment of brain diseases is that how do you know they're acting in the brain? And we can study this, again, using PET imaging to see whether or not a nicotine-like drug is getting into the brain and actually interacting with the acetylcholine system the way we think it is. And so as we used two tools here. First of all, we used a nicotine-like drug called Varenicline. Now, all of you have heard about this drug. This is Chantix. This is the drug that's used for smoking cessation. So this is a nicotine-like drug. It's been used at this point probably in hundreds of thousands of people worldwide. And it actually turns out to be very, very safe. Those of you who have seen the commercials will remember there's that guy at the end of the commercial is talking very, very fast and talking about all the bad things that could happen if you take Varenicline. It turns out that almost all of those bad things don't actually occur with people taking Varenicline. And on the bottom, this is a PET method where we can actually look to see whether or not nicotine-like drugs are actually hitting their target. And this is a measure of the binding sites, the receptors that nicotine binds to in the brain. And we did a study in which we exposed a small number of our Parkinson's patients to increasing doses of varenicline, starting with a very low dose, then working up to the dose that's used for treatment of smoking. And we were able to show that indeed it gets in the brain, it actually interacts exactly with the targets, the receptors that you'd be interested in. So this is an individual who's taking varenicline, and then this is the individual off varenicline. And you can see there's a big difference. And this allowed us to specifically select a dose that we could use for subsequent studies. So for subsequent studies, we picked a dose of 0.5 milligram twice a day, which is about half of what's used for smoking cessation. And then what we did is we did a study in which we exposed a group of our Parkinson's patients either to varenicline or a placebo for about 3 weeks. Then they stopped the drug, waited another 3 weeks, and then they reinitiated treatment either with varenicline if they'd had placebo in the first phase, or with placebo if they'd had varenicline in the first phase, so that we could compare the response within patients between varenicline and the placebo. And then what we did is we measured a number of different things. We measured standard measures of Parkinson's disease, we measured standard measures of cognition, and we measured gait and balance. And to measure gait and balance, we used a system that allows a measurement of a lot of different aspects of walking and posture. Particularly, this is a system in which an individual wears sensors on different parts of their body, and then we ask them to do simple walking and standing tasks so we can measure their walking and balance. And in particular, to measure their attentional processing, we used a test called the sustained attention test. This was developed by our colleague, Dr. Sarder, originally for studies of rats, but later adapted as an equivalent human test. And in this particular test, you receive a signal or no signal, then there's a delay, then there's a cue, and then you have to respond and say whether or not there was an original signal or no signal. And this is often done either with a plain computer screen or with a flickering computer screen. And I can tell you from my own personal experience, this is actually quite demanding. You really do have to pay attention quite stringently in order to perform well on this task. And our Parkinson's patients in particular have difficulties with this type of task. So what did we find? Well, what we found, first of all, that varenicline was very safe. We've now evaluated in a reasonable number of Parkinson's subjects, really none of whom had any difficulties with varenicline. So that's a key point. We did see a change in walking. In fact, our patients, when they took varenicline, actually walked a little bit slower. Now, that's not what we predicted, but as one of my colleagues like to say, it's plausible that people are actually walking a little bit slower because they're actually paying attention to their environment more. And in fact, in some Parkinson's patients, one of their problems is that they'll start to walk, the walking will speed up, and then they have difficulty stopping or turning. We saw a significant improvement in walking under distracting condition. So when people started to walk, if they were doing some distracting task, like counting backwards from 100, they actually were able to walk somewhat better. And we actually documented when people took varenicline that they had some improvement in their attentional performance on the sustained attention test. So I think what this tells us is that the varenicline treatment actually did what we thought it would do. It would change walking in a way that's consistent with what we believe from the animal experiments. And it did enhance attention, again, in a way that would be consistent with the way we think this drug is supposed to work. So this doesn't tell us that this drug would be effective and help Parkinson's patients, but it does tell us that either if varenicline or perhaps other drugs like varenicline might be useful in the future for actually would be worth evaluating in real clinical trials to see if we could mitigate some of the gait and balance problems that Parkinson's patients experience. And at this point, this would be preliminary, but I think we're hoping that at some point in the future we'll actually be able to pursue this in clinical trials in patients. And I think I'll just finish up by saying this is just an example of a way that we're trying to investigate a lot of complex brain circuitry. This cartoon is just the cartoon we use for sort of to show some of the circuits and connections. This is actually a very simplified cartoon of the circuitry. And what I've talked about is just one example or one aspect of the type of research we're trying to pursue to try and understand these kind of problems in Parkinson's patients. not just gait and balance, but other aspects of the way thinking and memory interacts, thinking and memory deficits interact with other aspects of Parkinson's disease to produce problems for patients. And our hope, like as we've done with the Varenicline study, our hope is this is going to generate some insights which will allow us to at least think about or maybe start planning the ways that we can improve treatment. So I'm done, and this is just some upcoming events, and I think I'll hand it over to Danielle at this point.
Yes, so thank you. Thank you so very much for that information. And yes, this is our next speaker series that we have coming up for November to finish out this year. If anyone is interested in attending this, then you can register. There's the information to register, or you can let us know if you need that link or check the website for that. So could you go to the next slide?
Oh.
All right, or is that
Sorry.
pass on? No, it's okay.
Not advancing here, just a minute. There we go.
No problem. Okay. And so now we're just going to open the floor for questions. If anyone has any questions, then feel free to place them in the Q&A box or in the chat box, and Dr. Albin can take your questions. Also, if you want to stay in the loop with the center, then you can subscribe to our monthly e-newsletter. There is the information. You can also find us on any of the social media platforms. And again, if you want that information, then it's right there. So I don't see any questions yet, but we'll wait a few minutes, give people time. But if there's anything else that you want to add or to say, then you have the floor. And oh, I got one. Would this be safe for someone to just try on their own?
I would say no, because so there is a lot of experience with Varenicline. Like I said, it's been widely used for smoking cessation. And I mean, I'm not exaggerating. I say hundreds of thousands of people have used it worldwide, and it seems to be very safe. But that's in that there's two issues. First of all, those are not in people with Parkinson's disease or dementing disorders. And second of all, when it's used for smoking cessation, it's usually for a fixed time frame in the range of weeks. So in our study, we exposed people for a period at most about 3 weeks. So at this point, we don't really know if there would be problems with more chronic exposure. And that would probably be, that would be the number one item if we take this farther in terms of clinical trials. The number one item would be to do a longer treatment exposure in subjects under careful supervision in the clinical trial to see if it's well tolerated, to make sure there would be no safety issues.
Okay, and is there any way for people to get involved with your clinical studies?
Yeah, so the Udall Center, we're recruiting for a variety of clinical studies. You could go to the Udall Center website, and there's a link there that you can sort of enter the system to indicate interest in studies. I'll mention we have a wide variety of studies we're doing in the Udall Center. We also have support from the Parkinson's Foundation for other related studies as well. And my colleagues here in our Parkinson's disease group are also pursuing a variety of clinical trials and other studies. So, we strongly encourage patients with Parkinson's disease or related disorders to participate in research. And, I think truthfully, a lot of our participants find it to be very rewarding.
Okay. Can you say more about any new findings on the association of LDB and PD?
Yeah, so that's a really great question, which honestly has preoccupied a lot of people in the area. We know that if you look at the tissue of the brain tissue of people with Parkinson's disease and Lewy body dementia, under a microscope, the kind of pathology that you see is really identical. And in people who usually pass away, which, after many years of disease, the distribution of that pathology is very, very similar. But it's clear that they are somewhat clinically different. So again, by definition, patients with dementia with Lewy bodies really cognitive impairment is the prominent feature at the beginning. Whereas in our typical Parkinson's patients, it's things like tremor and slowness of movement. So it appears that for reasons that we don't understand, the initial burden of injury really falls in different brain systems. And this is even complicated in Parkinson's disease because there are suggestions that there are sort of subtypes of Parkinson's disease where the disease starts in different parts of the body or different parts of the brain, and then may then progress or spread. So I think this is really an important area of investigation.
Okay, and so given the variable response to another treatment, okay, now this one is a tough one. So the
rivastigmine, yeah.
Yep, that's it. So do you think that treatment might also be relevant for specific patient groups?
Absolutely. So again, that's an excellent point, I would say. So I think, so first of all, our thought is that, as I mentioned earlier in the talk, these kind of acetylcholine deficits, they don't occur in all Parkinson's patients. They probably occur somewhere maybe 1/2 to 2/3, depending on the stage of the disease. And we would think that this kind of nicotinic treatment would actually be best by far in those patients who have those specific deficits. Now, the difficulty is identifying them. We did this with PET scanning, but that's a research tool. And actually, one of the goals we have in the next cycle of our center is to try and develop some easy ways of identifying individual patients who have those deficits without having to do a PET scan, which is, as a research tool, only available in a small number of places in the world. I'll also mention, you mentioned rivastigmine. I mean, that is a drug which increases acetylcholine, but not in a very specific way. And rivastigmine and related drugs have been tried for gait and balance problems with, I would say, mixed effects. At this point, I wouldn't say that they've been shown really to convincingly help fall risk or walking issues.
Okay, would you recommend clinicians encouraging their PD patient who are already on nicotine to continue for attention issues?
Well, it depends what you mean by nicotine. I mean, if you're smoking, honestly, you should stop smoking. And if you're Varenicline, to my knowledge, is the only real nicotine drug available on the market at this point. Again, that's used for smoking cessation. At this point, we don't know if it's safe for long-term treatment. So I would say no.
All right. Do we have any more questions? We have time for a couple more.
Yeah.
Thank you for that too.
Yeah, as a follow-up. Okay, the question here is a follow-up. Do you think a cholinergic treatment could be applied continuously, or would be more ideal as pulse generated? Again, that's an excellent question. I think the answer there is probably continuously. Again, the data that we have based on the normal function of the system is that this nicotine stimulation actually has a chronic, long-lasting effect, and that actually continuous stimulation would probably be the way to work with this particular aspect of the system.
Okay. All right. I don't think that we have any more. We still have time, a couple more minutes left.
Yeah, I think we can, the Udall link. So, a question.
Can you elaborate on the next cycle of the study?
Yeah, I will add that our questioner is a very sharp gentleman who is actually on the advisory board of our Udall Center. So thank you. So the next cycle of questions is next cycle of studies in the Udall Center is number one. We want to get a better idea of how these cholinergic system changes across the spectrum of the disease. So right now we have some insights that falls are associated with a certain pattern of deficits, and freezing of gait is associated with a certain pattern of deficits. But in one of our studies, we're doing a prospective study looking at our subjects we've characterized previously and continuing to follow them and doing more PET imaging to see exactly how things change across time and what brain regions. And then that would give us a better idea of what would be targets. Our colleague colleague, Dr. Sartor, is doing some detailed studies to look very precisely at information transfer between different aspects of these circuits. Again, that would allow us to identify some very precise targets for potential therapy. I'm particularly interested in a sort of a broader look at cognition. Some of our data from the last cycle indicates that there's a specific change in one particular brain system, which sort of magnifies throughout the whole brain in terms of how you coordinate different aspects of cognition. And that in turn suggests that there may be a specific subtype of Parkinson's patients that has this particular problem, and they may be the most prone to develop cognitive difficulties. And then the last thing that we're trying to do is to look at one very specific part of the brain. One of our colleagues, Dr. Ahmed, is looking at one specific part of the brain that's involved in spatial orientation and taking a very detailed look at exactly how acetylcholine influences the behavior of those nerve cells that are involved in really figuring out where you are and how to guide yourself when you're moving around. Again, a lot of this there's a lot of interest in terms of trying to understand these systems and basic features. But the implication is that if we know where problems are occurring, if we have some idea of how that information transfer is disturbed, we could potentially, we'd have some insight into targets for treatments.
Are there any similarities between the mechanisms of PD and Alzheimer's?
Mm-hmm. Yeah, so I guess it depends what you mean by mechanisms of disease. So if you're talking about the things that cause nerve cell death, that I would say is unclear. I think in Parkinson's disease, we think actually there are a number of different candidates for what causes nerve cell death. The proteins that we think are involved are different than the proteins in Alzheimer's disease. On the other hand, how do presumably those bad proteins actually cause nerve cell injury? At this point, it's not really clear, but there may be some overlap between the two of them. So energy production in the brain may be an abnormality that's common to both diseases. Mm-hmm.
Okay, and we have one more question.
Yeah.
Mm-hmm. Anticholinergic drugs are part of PD. How is this making sense of cholinergic synapses lost in PD?
Right. So anticholinergic drugs, these are older drugs. The one that's used the most is artane or trihexyphenidyl. These are older drugs. We actually don't use them very much at this point. They were historically used primarily for control of tremor, which they can be quite effective for. But anticholinergic drugs is a little bit like messing up your acetylcholine system. So messing up your acetylcholine system causes problems with attention. It causes problems with thinking and memory. And anticholinergic drugs can have the same problems. And this is particularly true in patients who have some degree of cognitive impairment, or even in normal elderly individuals. So at this point, we try to avoid those drugs for those reasons. Why they would be effective for tremor, for example, is something that's not entirely clear. We do know that there are changes in acetylcholine signaling in parts of the brain that we think are involved in the generation of tremor. And that actually is something that's being studied in our Parkinson's Foundation funded center. And it's probably that's probably the part of the brain where we think this effect of anticholinergics acts, but we're not sure. And this has been the topic of a lot of investigation just in the last 5 or 6 years.
All right, so it looks like we don't have any more questions. Anybody else? All right.
Okay.
Oh, I see something just popped up.
All right, thank you.
Thank you, outstanding. So again,
okay.
Thanks to everyone for your time and attention today. I just placed a link for the evaluation in the chat box. Please continue to fill that out and share your feedback with us. Thank you so much. Take care, Dr. Albin. Have a great day, everyone. Stay safe.
All right, thank you so much.
No problem.